Now? Yes, we have. Mark, you can hear us? Hi, Mark.
You hear me and see me?
Yes, perfect.
Can you hear me? Perfect. Well, good afternoon, everyone, and welcome again to Yes. We're performing the second live case. Let me show, if you want, to share with you the final end of the live case yesterday, yesterday live case. Can you see the screen?
Yes.
Okay, can you see the final engine? Yeah, okay. So if you remember, we had CTO, SFA, and stenosis in the P2, P3 segment, and the outflow on the foot, the only below the knee vessel was anterior tibial artery that was occluded in the mid part. So we perform a Rotarex as a thrombectomy, a mechanical thrombectomy to prepare the vessel in the femoral-popliteal vessel. And then we use DCB as scoring balloon and DCB in the first part of the SFA and the popliteal area. And the middle, we place Bayavan. And this is the final result, and using a non-compliant balloons in the anterior tibial artery. So the patient was good, recovered pedal pulse. So I wanted to show you the images. Any comment from the yesterday live case?
No, not at the moment. Yes.
No? Okay.
Yes.
Okay,
Mark,
perfect.
Mark, can you
Yeah.
share? This is Mahmoud Salah. Mark.
Hi.
Hi. How are you? Can you share the initial angio, because we didn't attend the case from the beginning?
No. Yeah, I don't know. I don't have the initial angio in the PowerPoint, but maybe we can connect later and we can prepare the basal angio of the yesterday live case if you want, if you prefer.
Okay. Okay.
It would be good for you?
Yes. It was a total occlusion of the superficial femoral, I believe. But if you have the opportunity,
Okay.
you can also observe on the screen.
Yeah, perfect.
So we can proceed
tomorrow,
with the
yeah.
next live case.
Yeah, ficat, vale. Can you see the screen? Yeah, okay. This is the live case today. It's a Rutherford 5 female with dry gangrene in the first toe of the left foot. We are performing a crossover approach using a destination sheath, and this is the basal angio in the FemPop area. You can see critical stenosis, pre-bifurcation, the profunda and the common and the superficial, a diffuse tight stenosis in the first part of the SFA. This is the CO2 angio. We have a short occlusion in the Hunter canal and stenosis in the popliteal area. It's a woman, so it's a small arteries, I think. This is, can you see the CTO angio? Yes?
Yes.
Yeah, perfect. So I think this is, yes, and this is another projection. Here, the only below the knee vessel is the anterior tibial artery. P3 is quite good, taking into account this is a female. Anterior tibial artery is good in all the territory. And the foot, the outflow in the foot is like this. So our proposal is to treat FEMPOP segment using a scoring balloon to prepare the vessel, to try to avoid flow-limiting dissections and to prepare quite well the vessel, and then using a tulip DCB 5 by 300 millimeters of balloon. So we will see if it would be enough just one balloon. I don't think so, because it's all the FEMPOP segment, but we can try it. What do you think?
Mark, this is Ahmed here. Your preferred strategy of scoring balloon in visible preparation in such case, what about atherectomy device?
Yeah, it would be an option, another good option. But in this diffuse stenosis, I think it's faster, and we can achieve also good results using a scoring balloon. It's faster and maybe it's cheaper in this case. So we have quite good experience using a scoring balloon and DCB in order to good patency, good payload stenting rate, and it's cheaper in our case. But it would be a good option also, the atherectomy device. But in this case, I think we can achieve good results as well using scoring balloon and faster.
Okay, so my second question is, this is a routine to use the carbon dioxide angio in comparing the contrast? You use the CO2 in each case?
I use, yeah. In this case, is the kidney has a moderate kidney failure, but I use routinely. In 60–70% of the cases I use CO2, because the question is why not? Yeah, maybe it's many of our patients has kidney failure. Sometimes we have allergic patients with allergic contrast. So we are training. So the different colleagues using a CO2, because it's difficult to visualize the first times using a CO2 in comparison with contrast. In my case, I use in the 60–70% of the patients, even those patients that doesn't have insufficiency, renal insufficiency, I use, because for me it's more comfortable and safety.
Okay. For time being, I think we have a question. Okay.
This is Hani Zaid from London. I can see there is a significant left common femoral artery disease.
Yes.
Maybe you can show, yeah. So can you elaborate on your algorithm, how you choose the treatment modality for this? Because probably in most of our practices, this would have been treated by endarterectomy and patch. And you can at the same time also treat the SFA. So just why did you choose to do it endo?
Yeah, in this case, many times we use hybrid approach, using a TEA, thrombus-endarterectomy device in common femoral artery, and endovascular treatment in SFA, popliteal area. In this case, we try to avoid stenting at that area. So I want to give an opportunity for the endovascular treatment. We try to place a second guide wire in the profunda in order to prevent some occlusion, or if the profunda is occluded, we can save. So I think in this short, no calcified lesion, I think it's a good option to try according to the other diffuse FEMPOP disease. Some cases we treat common femoral artery using a shock wave. In those cases that we have heavy calcified lesions, and with a very good results, since we have L6 shockwave device. So, but I still consider that the gold standard, at least so far, is endarterectomy patch and patch in this area. But some cases we can perform endovascular approaches. In this case, we have a frail woman, and we consider. But I fully agree that nowadays it's still on the endarterectomy device. But the shockwave device maybe is a real game changer, and even in this area. Do you use shockwave device in this area?
Anybody is using shockwave in distal femoral, common femoral? Nobody here.
Nobody?
No.
I mean, we've used it before, but the lacking thing is the long-term outcomes for shockwave.
Yeah.
So all the published data is just the acute procedural outcomes, nothing more than 30 days.
I fully agree, and for that reason, I think this is still the gold standard is still the endarterectomy, but always happen. The new device needs time to get evidence, and we'll see if we have a good evidence in the future. But I fully agree. For that reason, I consider the endarterectomy technique the first option in the common femoral artery. For that reason, because we have a lot of evidence, good evidence, in long-term follow-up. But we'll see in the new techniques using endovascular devices.
Okay, Marc, we have to leave you for a couple of presentations, and we'll come back to you.
Perfect.
Okay?
Yeah,
okay.
great.
So we can, if we have Nilo Mosquera online, do we have Nilo with us?
Nilo is online because he got an last minute issue last day.
Al revés.
So we can switch to the... Is a Zoom presentation?
Yeah.
A Zoom presentation?
Can you switch to Zoom with Nilo Mosquera, please?
Espera un momento, que tengo la línea. Vale. We are to do the definitive treatment using a tulip, a DCB balloons. So it's 5 by 300, and the second one will be 5 by 200. So to cover all the lesions, so it's 45, 50 centimeter lesion. So in the meantime, I want to show you the result of the vessel prep using an ultrascore balloon. Just a moment. This is the ultrascore balloon using a second guide wire to protect the ostium of the profunda. This is the angio after vessel preparation using CO2. I think it's quite nice. It's not flow limiting dissections. If you want, I perform also contrast angio to compare. This is, yeah?
Yes, it will be better.
Yeah, this is the after vessel preparation. Maybe in the ostium of the SFA it could be a mild dissection. It's also the guide wire too, we'll see at the end. This is the proximal part and the popliteal area. This is the CTO angio. The dynamics is quite good. And this is the contrast. So according to the result, we follow to use dry cutting balloons to try to follow the leave nothing behind strategy. What do you think about the result so far?
It's quite good in order to play now with the drug-eluting balloon. It's quite good.
Yeah. We are trying to find the proximal marker. Aguanta aquí. Ves retirant tu.
Mark, the patient is under general anesthesia or local anesthesia?
In this case, we have a barrier idiomatic because, yes, perfect, here. And this is a general anesthesia because it's from Pakistan and she doesn't understand Spanish, Catalan, and English. So
But
it's,
no, my question is related to the markers you are on the screen. You are fixed on the screen, but they are not on the skin of the patient. So if the patient moves,
it's in the, it's just in the screen. For me, it's more efficient. And this is, but in this case, it's a general anesthesia. Assist?
Marc, it's Fernando. Can I make you a question?
Yes, of course.
Yeah, when you treat this kind of lesion, you are treating the ostium of the ACFA and the common, and you are protecting the profunda, okay? With a guide wire. How do you deal with this bifurcation? I mean, because sometimes we see it. We are aggressive with the stenting of the ostium of the ACFA, and we see like a small, like narrow at the origin of the profunda or not. Would you treat it or not?
Yeah, I also protect, I always protect the profunda just in case. So in this case, the ostium is not affected. The lesion is per bifurcation and of course, the SFA, not in the profunda. So I just protect in this case. But if we have some problems during the dilatation, I have the guide wire in place. When we have both osteums affected, I treat almost always both osteums. We operated on a lot of critical limb ischemia, so we give priority at the SFA to achieve inline flow on the foot.
Yeah, but
I
Marc,
consider.
Yeah, the key point here, we have learned from our seniors the importance of the profunda and how profundoplasties have many legs. So in this case, sometimes I prefer to be sure that the profunda keeps well patent, that only trust in the SFA. What do you think?
Yeah, for me, the profunda is important, but in critical limb ischemia, so not in rest pain, so in ulcers, so in lesions in the foot, I think it's most important to get a direct flow in the foot. So I give priority in the SFA, FEMPOP, and below the vessel. So of course it's important vessel, but in critical limb ischemia it's different. So in claudicances, of course, in rest pain it's of course.
Marc, let me make a pull question to the audience. Who is in favor to prioritize the profunda? Who is in favor to prioritize the superficial femoral?
In critical limb ischemia or in other situations?
Nobody prioritizes nothing.
Okay.
Yeah, so probably it's too early.
Can I just, is there an option to keep both of them?
Yes, of course.
So because I think one of the challenges here obviously is that you have a balloon across the origin of the profunda, so you might have to make a choice between both of them. It might be safer just to do something which you can actually preserve both of them.
But in terms of prioritization, my question was directly, is if you need to prioritize one of them, which one is the preferred? Profunda?
I will never lose the profunda.
Never.
Yeah, I'll try to keep the profunda.
You lose the profunda. SFA is more convenient than profunda. Yeah?
No,
Okay,
well,
I not agree with about that. Okay.
yeah, can I just? I think it's very important to get this right, because those patients, this is chronic disease. This is not the end game for them.
Yeah.
It's very important to preserve the profunda, because whatever you do to the SFA is going to occlude, and hopefully it will get them over the tissue loss, but you keep the profunda so they don't go back to rest pain. If you lose the profunda and the SFA occludes, then you're back to square one. So I don't think it's not a question about is there an option, who do you prioritize? There's one correct way. Let's keep both.
Both is the preferred one.
Absolutely.
Both, but it's the easy answer.
Yeah,
This is the easy answer.
This is the idea. I think, like Professor Hani said, it's not a kind of prioritizing one over the other. We have the main goal is to have both of them patent. We have to keep the profunda patent as much as we can. But if you have a must to prioritize one of them to keep a flow, my opinion is still to have a direct flow with SFA. Not to sacrifice. If I have an option to save it, I will save it.
Can I say something? I mean, yes, I mean, profunda is the most important.
Exactly. This is the point. More beneficial for some time. It's not giving the full benefit for the patient, but I know that the what we are doing as an angioplasty in a chronic patient will have a recurrence, and we still have a second session for this patient. We can give him another chance and another chance, but if it's hopeless and I cannot do anything with SFA, for sure I will secure the profunda and keep the patient with profunda patent.
Can I say something? I mean, if we get to the point we have to sacrifice one of them, I think we have to go open, because I think it's not acceptable to sacrifice any of them.
So
So to get to the point to choice, we want
yeah.
to sacrifice one of them, I think we should stop endo and do an open repair.
So it's important to preserve the profunda always. Yeah, that is the first scenario. Yeah.
And the second
Talk about, yeah. Always profunda.
The second question here, if we have to stent this area, Mark.
Sorry, stent in the common femoral artery?
Yes, if you face the situation now that you have to stent this area, what would be your strategy here?
What kind of stent, or if we convert to open surgery?
Actually, where to deploy the stent, where is your landing point, and how you can spare the profunda also?
If I need to place a stent in common femoral artery, I place only super stent. For me, it's the only stent useful for common femoral artery, because you can repuncturing this stent, so you don't lost the access. And if you want to perform later for any reason open surgery, you can remove very easy the super stent in common femoral artery. So it's a good question if you need to place an stent across the profunda or across the SFA. In my experience, I try to if I cannot perform a kissing stent or a culotte technique or what else, or whatever, I try to prioritize if it's a good SFA, a good FEMPOP axis. I try to prioritize that axis, because it's for for futures reinterventions, I think if you don't occlude the FEMPOP area, it's better. So of course, I fully agree that if we can preserve both, it's better. And one option would be open surgery, clearly. But in this case, if I would have, it's not the case, so I am going to show you the final angio. But if I would need, I would have needed the stenting in the FEMPOP, in the common femoral artery, so I would have placed the superstent inside the SFA, not the profunda.
Okay, Marc. Can we leave you for a few minutes for another presentation, and then we'll come back for you for the final?
If you want, I can show you the final, because we are finished. So this is the outflow on the foot.
Okay.
This is the final angio. This is the outflow on the foot, and I can show you the other angios. This is the anterior tibial artery. At the end, it's coming. Sorry. This is the popliteal area, the P3 segment, without flow limiting dissections, without recoil, without needed for stenting. This is the mid SFA, and the hot issue would be this area in the common femoral artery and the profunda.
Okay.
What do you think? So profunda is patent. Do you need another projection to be sure, or
maybe mag, one mag magnification of the bifurcation.
Okay, perfect. Okay. 4-4. Puja una mica l'arc, sisplau. Vale? Més amunt? Més amunt. Sí. No tant. Vale, aquí... 4-4. Sí. ¿Por guías? We are removing the guide wires because we want to show you without guide wires there. What do you think? We have a mild, I think, dissection in the SFA at the beginning, but the flow is quite good. The profunda is patent, and the lesion of the common femoral artery, I think, is not an issue.
I guess it's good, Professor Mbao.
Don't touch anymore.
No.
Yeah, but it's. I fully agree. But are you okay? Are you happy
It's okay,
with the
okay.
result?
Yeah, we are very
Okay.
happy about that. You have a comment from the floor?
Okay. Femosil, sisplau.
Yes, it's a nice case, but there is a small dissection. I think if you wait for 10 minutes to be sure that this is not a flow-limiting dissection, he can
Okay.
leave it. But if not, don't gamble with leaving this. If it is limited, will limit the flow, you have to do small incision, endarterectomy, plus or minus profundoplasty to finish the hassle of
Okay.
So we came back to the first
Peaceful
point again, Professor Shakawi. So we came back to the first point that the patient should be operated from the
What
start.
about to perform IBUS checking here?
Not
Time.
IBUS, but EBUS. So we are performing an extravascular
Okay.
ultrasound checking. So in the meantime, we are waiting for 10 minutes. If you want, I can
Yes.
show you the final angio 10 minutes later. And in the meantime, we are checking
We will be back to you
by
after.
ultrasound. Perfect.
Yes, we will
Okay.
proceed and be back to you.
Perfect.
We move?
Yes,
We
we
move.
will move. Yes, Martin Schroeder is online.
Muntem l'eco?
Okay.
Ah, no, espera que esperarem 10 minuts.
We'll come
Vale?
back to you, Mark.
Okay.
We have now another online presentation from
Encara
Martin
no l'obris?
Schroeder
Muntem
from
l'eco,
Germany.
que vull veure...
Can we shift to the Zoom presentation?
Can we go live again, please?
Can you hear me?
Yes.
Okay. Can you see my screen?
Yes.
Because the procedure is finished. Okay. So this is the two angios. In the left side, you can see the time, and the right side on the top, 15 minutes later. So I think it's the same. The dissection doesn't advance. And the ultrasound, the EBUS, you can see at the bottom of the left screen, you can see the wave, Javi-Fasik
Yes.
wave, 178 centimeters per second. So I think it's quite good, taking into account that it's just after dilatation, so the velocity it's normal. So what do you
For
think?
me it's good. I don't know for.
I think it's excellent, Mark. It's an excellent hemodynamic and geographic result. For the,
15 minutes
for the
later.
clinical result also. Yeah.
Okay.
Thank you, Mark.
Thank you. Thank you to you.
Bye.
Bye-bye.
Next presenter is coming from Lithuania. Is Thomas Baltrus. Is here? Okay, Thomas. Talk about endovascular robotics, the past, the present, and the future. Back to the future.
Good afternoon. It's my pleasure to participate in this nice congress, and thank you, Professor Salah and Professor Sakr, for your kind invitation and adjusting actually my